All right. We're going to get going. I'm Dr. Marv Slepian, and
I'm Neil Owiel, and thank you for joining us for the last session of the evening.
exactly. What we're going to do first is have our panelists introduce each other. Let's start with Dr. Slaughter.
Hello, Mark Slaughter, Chair of Cardiothoracic Surgery, University of Louisville.
David Feldman, I'm a cardiologist in upstate New York.
Daniel Bakker, intensivist in Brussels, Belgium.
Paravov, cardiac surgeon, chief of MCS department in Berlin, Charité.
And the best surgeon in the world. There you go.
No. Did you see my right ventricular failure rate?
We can have a little fun. It's 5 o'clock. Go ahead.
Manish Patel, cardiothoracic surgeon, UT Houston.
Phyllis Bilia, medical director, MCS Toronto.
Got it. All right, listen, let us start. Nir, why don't you introduce us?
Yes, so the first speaker is Dr. Amanda Vest, coming for us from Cleveland Clinic, and she will speak with us about assessing the right ventricular function on VA ECMO. Amanda, thank you for joining us.
Thank you so much for having me, and thank you, Marwan, for inviting me for this talk. So in the next 7 minutes, I'm going to talk a little about how we might assess RV function on VA ECMO. My funding disclosures are not relevant, but I should probably disclose I don't think I always get it right when trying to predict which RV will fly when we're coming off of VA ECMO. So I have some questions on this topic, and hopefully we can all learn a few bits and pieces together. So I went to the literature to ask, how does VA ECMO affect RV echo and hemodynamic parameters? What features have been shown to be predictive of a successful wean off of VA ECMO? And what might be best practices or clinical pearls around ensuring optimal RV function when de-escalating off of ECMO support? So we're very familiar with these pressure volume curves in the setting of the LV going on to ECMO. We see here the cardiogenic shock loop in black, then subsequent colors up to the 4 liters of flow in orange. And as you know, we get the increase in LV systolic pressure, but at the expense of a decrease in stroke volume. So a narrowing of the width of that loop as the heart is trying to eject against the retrograde arterial ECMO flow. So that's the left. On the right, we actually see the opposite direction of the loop. So you've got the black loop for the failing heart, and then moving downwards. And that represents the venous cannula unloading the RV, causing a flow-dependent decrease in end diastolic volume, but also a decrease in stroke volume, at least in the setting of a fixed RV contractility and pulmonary vascular resistance. Of course, those things may not be fixed. Those things may change and be dynamic during the course of the sick patient going on to VA ECMO. And so here we have a porcine model to inform us a little bit about RV-PA coupling in this setting. So these are 13 pigs, but normal pigs. They're centrally ECMO cannulated, and their flow is reduced from 4 liters, which is in the black here, and then down to 1 liter of flow in the orange. They did baseline weaning, and then also used hypoxic vasoconstriction to simulate an increased afterload clinical scenario. And so what you see here is, again, on the top, that same relationship with the flows being increased and the curves moving over to the left. But then on the bottom, we see the relationship in the setting of hypoxic vasoconstriction. And you note there that there is evidence that the RV is able to adjust its contractility, so that's the steeper line that you see of the contractility line, to meet this higher pulmonary afterload in the hypoxic vasoconstriction setting. So evidence here, at least in a heart with decent function, of RV-PA coupling being maintained. Of course, we need to go to real patients to really understand what's going on. These are 87 adults from London. And in this group, the Royal Brompton investigators found that actually there wasn't much change in the echo parameters of the RV during the course of ECMO support, pre, 24 hours post, and at the echo prior to decannulation. They did identify some predictors of successful VA ECMO liberation that related to the RV, and you see the most notable one here being normal RV systolic function before going on to ECMO. In the echo on the last day of ECMO support, you see actually RV dilatation did not predict whether or not liberation was going to be successful, but normal RV systolic function was again a positive feature there, as well as improvement in RV function. But notably, they just saw these improvements in RV systolic function for individuals who went on to ECMO with acute RV dysfunction and not those who had longer standing RV dysfunction. There's a series from Milan, which also looks at some of the echo parameters. So they did find that a higher TAPSE was predictive of likelihood of successful weaning. That was measured on full ECMO flow. They also found that the lateral S prime over RVSP being higher was associated with successful weaning, and that held true both at full and minimal ECMO flows. And it actually outperformed the conventional LV echo parameters, which was interesting. But several in the field have made the case that regular 2D echo is insufficient to really be a strong predictor. And so I was interested in this study of adults in Taiwan, in which a 3D echo was performed to assess RV function just before decannulation. And the average flow of individuals in this study was about 2.6 liters, so moderate flows. And they did find this cutoff of right around 25% as being the threshold for distinguishing a patient that was going to do well. So that gave an area under the curve for successful liberation of 0.9. And as you see in the little Kaplan-Meier curve here, it also performed very well as a cut point for indicating better survival. So, of course, when we're assessing our patient and maybe have used some of these parameters to assess the likelihood of successful RV liberation, we're also going to be thinking about, well, what can we do? We know that the RV that is improved out of its acute right heart failure is also going to be a predictor of successful liberation. So, of course, we're trying to decongest the patient if congestion was an issue to get that preload as good as we can. And even though in the normal heart there may not be a huge amount of impact from hypoxic vasoconstriction, we certainly don't want to be trying to take our patient off of ECMO in the setting of significant lung disease and when there's an ongoing oxygenation issue. We may need to correct arrhythmias, as was just discussed. But another thing clinically we should just keep an eye open for is the possible occurrence of north-south syndrome. And this was a nice case report really illustrating how this can affect the RV. So this was a 55-year-old gentleman with ARDS, and as his LV was recovering, improved cardiac function, increase in transpulmonary blood flow, and ejection of that poorly oxygenated blood, leading to north-south syndrome or Harlequin syndrome. And they found that in this case, actually a conversion over to VAV ECMO, which is often our next step if someone shows north-south, was not helpful due to the RV being really very unable to manage that increased preload, as shown in the echo stills at the bottom. They converted over to VVA, which did unload the RV, stabilized the patient, and enabled them to successfully liberate. So, in summary, 3 questions we may have answered here from some limited data available. VA ECMO decreases stroke volume on the RV pressure loop recordings, but the echoes seem to be fairly stable for the RV parameters on support. We do see some echo markers of successful liberation, including that 3D RVEF greater than about 25%. And we have to consider that we've done everything we can to optimize that RV before trying to wean, including then clinically monitoring for north-south as we come down on flows. Thank you very much.
So this presentation is open to questions, and maybe we'll ask Phyllis, you deal with a lot of ECMO wean as well. How do you assess the RV? Well, clinical tools like samples?
Well, we do daily echoes, looking not just at the RV, but also the LV as well. So both ventricles need to be assessed. We had done a small study actually using inhaled nitric oxide to see if we could support the RV in certain situations, and it seemed that we were able to actually wean the RV. The RV support was better with inhaled nitric oxide. Very expensive way to do it. I was having my wrist slapped every time I tried to do it. But the daily echoes were really helpful, as well as a protocolized wean approach to how you do this rather than just turning down the dial. So we'd go down to 50% of support and then another 50% and see what the RV would do. We use the same parameters. I think it's idealistic to really assume that you can get a 3D reconstruction of the RV on a daily basis. Good luck with that. But I think TAPSE, TS prime are easy enough to do. It's also, I mean, I tend to be at the bedside when these echoes are done and push our echographers to actually get the images that are required in order to do that. So you really have to want the images, you should be there to help with them, and then really push for protocolized assessment.
Evgeny, different in Germany?
Before I ask your question, I have one own question to you. The scenario is the LV is poor, the patient is on ECMO, and you have to judge the right ventricle before you implant LVAD. So, in my opinion, if we unload complete, if we drive the ECMO in the full flow, so we load the left ventricle, we increase wedge pressure, we increase afterload for the right ventricle. It's difficult to judge the right ventricle. If we downgrade the ECMO and we drive only 1-2 liters, then the wedge pressure is still high because the left ventricle is bad. So at the same, in my opinion, it's very difficult, as answer to your question here, it's very difficult to judge the right ventricle on ECMO. And we publish right now the multicentric study, just European Journal of Heart Failure, published yesterday, has been shown that the patients who was transferred from CP, partial unloading, or from ECMO to durable device, they developed a much more right heart failure on durable device than patients who are transferred from 5.5 or ECMO plus 5.5. So, and then it's back to you, how do you judge such patients with bad left ventricle scheduled for LVED, and how you judge the right ventricle in this situation?
Yeah, it's incredibly difficult. So, you know, I was interested in the literature that there were even predictors that were associated with the ability to successfully liberate, because I thought going to the literature, I may not even see anything that was associated. I didn't see any papers relating to the scenario you were describing. If you have a patient on VA ECMO who you think you're going to progress onto durable LVAD support, I think that's an incredibly difficult scenario. And other than trying a combination of all the things that have been mentioned and really going up, going down, interrogating, taking off the inotropes, doing all those things and checking out how the echo looks. I think that's all I would do in terms of trying to satisfy myself that that RV was going to be able to cope with isolated LVAD support.
All right, this is an exciting topic. I had a question, but we're going to honor our time commitment, so thank you very much.